Ranger falls 60 feet from a Black Hawk, closed head injury, femur fracture, broken arm, bleeding from the nose and mouth, unconscious. You're a single medically trained provider. You have the gear that you brought in with you. How do you manage that? What are your priorities? This is where TCCC comes in. So studies of modern military conflicts have shown that 90% of combat fatalities occur before the casualty reaches a medical treatment facility. So the pre-hospital phase has been the focus of decreasing preventable combat death. So TCCC outlines the priorities of care in combat applications. So in terms of a brief history, TCCC was created in 1996 after conflicts in Iraq and Somalia, like the one that you saw depicted in the Black Hawk Down movie there, demonstrated big differences in how civilian and military trauma was practiced. It was originally designed for Naval Special Warfare Command, so that's the Navy SEALs, and the Committee on TCCC, which was created in 2001, continues to update these guidelines semi-annually. In terms of the Canadian context, it was adapted by our Special Forces in 1999 and to our conventional forces in 2002. The goal of tactical combat casualty care is to treat potentially preventable causes of death on the battlefield. It's got three main objectives: treat the casualty, prevent additional casualties, and complete the mission. So these goals are under the guiding principle of providing the right medicine at the right time. The challenge here is that good medicine is often bad tactics, and bad tactics get you killed. So the optimum care of casualties may be in direct conflict with the goals of the mission. So TCCC recognizes this, the unique challenges that are faced, and offers a prioritized approach based on the most common causes of death, as well as the level of threat to the provider. So we'll take each of those in turn. In terms of the most common cause of preventable death on the battlefield, they are in order of frequency: massive hemorrhage, airway compromise, and tension pneumothorax, taking up 91, 8, and 1% of preventable combat deaths. It's important to note here that though TCCC was designed for the military context, the civilian context, obviously, is not devoid of these types of injuries, and so the civilian equivalent is tactical emergency casualty care, TECC, as opposed to TCCC, TCCC. And we'll take this opportunity to talk about the differences in injury patterns that are seen between those two things. So everything in my talk has 2 or 3 reasons for it. So 3 differences between TCCC and TECC, the military and civilian context, are the level of protection, worn or not worn, the population itself, and the mechanism of injury. So in the civilian context, people aren't walking around usually with helmets and body armor, and so there's more head injury, torso injury, abdominal injury, more injuries per person, and less exsanguinating extremity injury. In terms of the population, civilian populations, as we see, have comorbidities. There's young people, there's old people, there's medications that normally aren't present in the military context. And in terms of the mechanism, military injuries are usually penetrating, 75% being gunshot wounds or explosive fragmentation. And the mechanisms of injury are usually higher energy, higher lethality. So with those differences in mind, the principles governing TCCC and TECC are largely the same, and mastery of one definitely translates to the other. With that, we've covered the principles, the goals of TCCC. How good is it really? So widespread implementation of TCCC is shown throughout the military literature to have decreased preventable combat deaths. So if we take a look at just one telling metric, our case fatality rate, the percentage of fatalities among those seriously wounded, and we look at modern military conflicts, we see that as TCCC was implemented, we have a decrease in the case fatality rate. So OIF and OEF are Operation Enduring Freedom, Operation Iraqi Freedom. Now, this isn't a perfect metric because a lot of other things have changed as well. There's differences in protective equipment, training of medics, better transport times. But if we take a look at this retrospective study that compares 2 groups of soldiers between 2001 and 2010, the 2 groups of soldiers being the U.S. Army Rangers, who you saw in that video, which is a special forces group within the Army, versus the rest of the U.S. Army. Over that period, the Rangers had a preventable death rate of 3% versus the rest of the Army having a preventable death rate of 24%. The only difference in their medical training being that every single Ranger was trained in TCCC, whereas in the Army, only the medics were trained in TCCC. So TCCC is effective at reducing preventable deaths in the operational setting. So now that we've talked about that, how do we actually do TCCC? So again, it's intended to treat potentially preventable causes of death on the battlefield within the context of the tactical scenario. So it only allows certain interventions at certain times based on the level of threat to the patient. So these 3 phases of care based on level of threat are care under fire, tactical field care, and tactical evacuation care. So we'll take each of those in turn. Care under fire is basically combat's ongoing, you're receiving effective enemy fire, every hand is needed to gain fire superiority. There's an acronym for this, as there is for everything in military medicine, and it kind of reflects your mindset going through this type of scenario. So it's fire back, treat unconscious patients with a recovery position, and uncontrolled hemorrhage with tourniquets, get to cover, and keep moving. So only 2 medical conditions are allowed to be treated, massive hemorrhage with tourniquets and airway compromise with recovery position. When you're not undergoing effective enemy fire, you enter tactical field care. This is where most of the medical interventions are going to take place, and you have the gear that you carried in with you, and that's it. And then tactical evacuation care is basically transport medicine on the way to a medical treatment facility. So back to our case. Our soldiers fall in 60 feet in the middle of a combat zone. What are your priorities? What do you do? But let's translate this back to a parallel civilian scenario. So you are a single coverage ED physician covering a locum night shift in Fort Francis, Ontario. You're hanging out in the house next to the ED. This trauma patient rolls in. You're the ED doc and the code team all rolled into one. You have 2 to 3 nurses cross-trained in ED and ICU. You do not have a CT scanner. You don't have X-ray or ultrasound overnight. In terms of specialist support, you have a GP anesthetist and a general surgeon, both of which are on call but not in-house. In fact, they're both on a duck hunting trip, which is the same trip that the normal ED doc is on, which is probably the reason for your locum in the first place. And it's pretty much the same injury pattern. Instead of falling, a teenager jumps. Oh, you have a 2-bed ICU, but you're also covering that. Same injury pattern. How do you do this in a resource-constrained setting? So let's talk about the MARCHE algorithm. So you can think of the MARCHE algorithm as a prioritized, high-yield set of interventions to save the most lives in the least amount of time with the least supplies. The approach has been applied and validated throughout the military literature and can be applied to anybody in a resource-limited setting without definitive surgical support. You can also think of it as the set of skills that a junior resident should learn in order to be effective in a trauma wave. These are your high-yield set of skills, the things that you can fix with not too much equipment. So the term was coined by the late Canadian Lieutenant Colonel Aaron Savage, and you'll note that the first 3 things are addressing the top 3 causes of combat death. So massive hemorrhage. So this is controlling, assessing hemorrhage with tourniquets, hemostatic dressings, junctional tourniquets. Airway is pretty much the same approach that we normally have, except the definitive airway management of choice is going to be a crike as opposed to an intubation. If we have time, we can talk about how dangerous it is to do an intubation in the middle of a combat scenario, but you can kind of imagine. Respirations is going to be your chest seals, your needle decompressions, your chest tubes, applying oxygen if you have a portable chemical oxygen generator. Circulation. So this is a big part of this, and damage control resuscitation is a large part, but we won't talk any further about that. There's a grand rounds by Chris Funk last year that goes into it, and it's a huge topic in and of itself. But other things are IVs, TXA, pelvic binders, assessing perfusion, and mental status. And from there, you move on to head injury and hypothermia, and eyes and everything else. So the MARCHE algorithm in and of itself is going to deal with the most common life threats. And when you go from there, you can expand it and add pause B to that. So pain, antibiotics, wounds, splinting, and burns. And you can also add SMARCHE for shoot back, and that takes into account care under fire. So this is your basic and prioritized approach to the trauma in resource-constrained environments, focusing on identifying and treating the most common life threats while leaving out any extraneous investigations or other steps. Let's actually talk about another case to highlight some lessons that can be translated from the battlefield to the home front. Gunshot wound to the upper thigh, femoral artery is injured, gaping hole in the leg, blood's everywhere. Again, single medically trained provider, you have the equipment that you brought in with you. Let's talk about junctional hemorrhage. So, as we've kind of beat to death already, rapid hemorrhage control, super important in the military context because it's the most common cause a preventable combat death, but it's also a very important cause of death in the civilian context. But what do you do with massive hemorrhage when you don't have definitive surgical control? What do you do when you can't just throw on a tourniquet? There are options, and we'll talk about each of these guys in turn, but hemostatic dressings, junctional tourniquets, and XSTAT is another one as well. So in terms of our hemostatic dressings, it's actually interesting to note that the Stop the Bleed campaign recommends hemostatic dressings, and our EMS as well as our tactical EMS colleagues have these. So we have to be aware of them, their complications, and their capabilities. In brief, there's 3 ways that hemostatic dressings work. One is by factor concentrator. So this is how quick clot combat gauze works. Basically sucks away the water content of blood, increasing the factors, increasing clotting. It can also be mucoadhesive agents, like Celox here, so physical binding to tissues, physically blocking the ability to bleed. And then they can also be procoagulant supplementers. Super important to note that you need to apply 2 to 5 minutes of direct pressure with hemostatic dressings, or else they're actually not any more effective than normal gauze. The only complications that have ever been noted were burns from quick clot granules, which are actually no longer used, no longer produced. The evidence behind these guys is summarized in 3 recent systematic reviews, which all noted lack of high-quality evidence because all of the studies have been completed in swine models or a limited case series. But with that caveat in mind, with the outcomes of rebleeding, subject mortality, and initial hemostasis, the TCCC approved hemostatic dressings were found to be effective. And the Committee on TCCC has also done a synthesis of all of these studies, looking for if there's any one brand, any one model that's any more effective, and they're all basically the same. Just briefly, another option is junctional tourniquets, which are a lot more cumbersome, a lot more difficult to use, a lot more difficult to store, and so they're used a lot less. They all work by the same mechanism, though. They apply pressure to the femoral vessels between the acis and the symphysis pubis. And then there's the XSTAT. So these are non-absorbable, expandable hemostatic sponges that are delivered directly to the site of the wound. They actually have little radio-opaque markers in them, so you can go and find them later should you need to. And the idea here is the expansion of the sponges as well as direct pressure causes tamponade of the bleeding. So the options that we talked about, hemostatic dressings, junctional tourniquets, and this XSTAT tool. So that's actually our whirlwind tour through tactical combat casualty care. And this is what I've hoped you can take away from this part of the talk. So TCCC is the standard for initial trauma management in the operational setting. In the resource-limited setting, you can incorporate this organized and prioritized approach into your initial trauma resuscitation. You can add in labs, imaging, adjuncts as they become available, but keep in mind this focused approach because it focuses on the identification and treatment of the most common life threats. And then I hope you can just recognize the options for junctional hemorrhage should they show up in your emergency department. With that, we'll change gears and move on to prolonged field care.